Well, hi, this is Randy Wyckoff, the Dean of the College of Public Health, and I'm really sorry that I'm not there with you today, but I am pleased to be able to share with you some information about understanding and improving health in Central Appalachia with a talk that I'll subtitle, How High is the Wall in Your Town? Now, when we talk about Appalachia, of course, there are multiple different meanings. Most folks recognize that it is a mountain range in the eastern part of the United States. Hikers see it going from Maine to Georgia. The Appalachian Regional Commission defines it going from New York to Mississippi. If you take all of Appalachia, it's about 420 counties in 13 states. It's about 8% of the U.S. population, with about 25 million people living there. About twice as likely to be rural and more likely to live in poverty. When most people talk about Appalachia, though, they're not talking about the entire mountain range or all the people that live there. They're really talking about Central Appalachia. That's these 238 counties here in the middle that represent all the counties of Kentucky, North Carolina, Tennessee, Virginia, and almost all of West Virginia and a little bit of Ohio. Less than half of all of Appalachians live in these counties, but we are much more likely to be distressed or at risk. Now, the reason folks think about this is because our statistics are so much worse here. If you look at the clustering of unemployment in Appalachia, you can see it's more common in the central part. If you look at issues like high school non-completion, you see it's worse. If you look at issues like poverty clustering, you see it there. If you look overall at distressed counties, you can clearly see that it's a problem. And indeed, when most people think about Appalachia and the poverty and the health challenges and the social issues that we face, this is the part of Appalachia that they think about. Now, for today's talk, I'm going to use a subset of all of Central Appalachia, and that is what I would call our region, the region that East Tennessee State University serves. That's the 8 counties in northeast Tennessee and the 9 counties and 2 cities in southwest Virginia. I could show you statistically that it's basically like the rest of Central Appalachia, but in the interest of time I won't do that. It is a region of incredible natural beauty and a deep and rich culture and heritage, and I hope that I have the opportunity to host some of you up here in the near future. But we have some particular health challenges as a region. So to address this, I'm going to pose and answer 2 questions. What is the health status of our region, and what can be done about it? Well, to understand the health status of our region or any state, of course, you have to start with an understanding of the health status of the overall country. And as you all well know, the usual statistic that we use in public health is life expectancy. It's the most basic fundamental measure of health. It reflects the totality of health, social, and other conditions that people live in. And if you went out in the streets of Appalachia and you asked someone to tell you something about life expectancy in the United States, they'd tell you 2 things. First, that it's probably the longest it's ever been, and of course the man on the street would be right. In 2012, life expectancy in the U.S. was about 78.5 years, representing a phenomenal increase in life expectancy. So from the time my grandparents were born to the time my youngest daughter was born, life expectancy in our country went up by 30 years. Of course, the man on the street also would tell you that life expectancy in the United States is probably the longest in the world. And as you well know, here the man on the street would be wrong, and the U.S. ranks behind all of these other countries. But as disturbing as this statistic is, it becomes even more disturbing when you realize that life expectancy or premature mortality is not distributed equally around the entire United States. So what I've done in this chart is I've taken all 3,144 counties or county equivalents in the United States, and I've ranked them for their premature mortality, which in this case is years of productive life lost from the county health rankings, and you can look up the methodology there. But all you need to know is that the median county here has a value of 8,107. The top 10% begins at 5,500. The bottom 10% begins at 11,600. So here you can see, looking at all counties in America, there's a 2-fold difference between the 90th percentile and the 10th percentile. Now I'm going to drop the 2 tails of this, and this is the same chart again. Now what I'm going to do on this chart is I'm going to show you our region. Here are the 8 counties of northeast Tennessee, and here are the 9 counties and 2 cities of southwest Virginia. And what you can see is that 100% of our counties in this region fall in the bottom half of America, and in fact 2/3 fall in the bottom quarter. So at this point, probably instead of asking what, most of you are asking why. Why should a baby born in our region be more likely to live a shorter life than someone born in most other states and in fact in dozens of other countries? Why do we have health statistics in Appalachia that are so much worse than we could achieve? Well, here again, it's worth looking at the United States as a whole. I think you're aware that there was an article in the New England Journal in 2007 that laid out the factors that contribute to premature death in the United States. They include genetics, environmental exposure, social circumstance, and then people are often surprised to learn that healthcare only accounts for about 10% and behaviors account for 40%. Well, this is national. Which of these are relevant to our region? Some folks sometimes believe that maybe it's genetics, maybe there's something about the people that live in Appalachia. It's not entirely impossible. If you look at the distribution of Scots-Irish in America, you do see a clustering here in central Appalachia. But there's really no reason to believe that it's genetics that causes us to die young. And in fact, information from this woman suggests otherwise. This is Bess Brown Cooper, was born in 1896 right here in Sullivan County, which is one of the counties in northeast Tennessee. She graduated from my university in 1916. She was our oldest living alumna. We know that because for 2 years, from January 2011 until she died just a few months ago, she was the world's oldest living person. Not the oldest person in Tennessee, not the oldest person from East Tennessee State University, but one of only 8 people ever known to reach the age of 116. And that proves absolutely nothing except to suggest that it maybe isn't genetics that's accounting for our lower life expectancy. Well, what about healthcare? Maybe it's our healthcare is so bad that we're just dying young. And as with most parts of the country, we do have health professional shortage areas here. But, you know, the county health rankings rank all 95 counties in Tennessee, and if you look at the ranking for clinical care, the top 5 counties include 2 right up here in northeast Tennessee and another in the Appalachian part of our state. So again, yes, we certainly have health challenges related to health care, but that's probably not the reason that Appalachians are dying younger. Well, what about behaviors? Well, of course, this is where the real information is. Most of you are well aware of the reports from the CDC laying out these factors being the things that cause Americans to die young, the actual causes of death, and no surprise to you, tobacco leads the list. What do we know about tobacco use in our region? Well, here's all the counties of America. Here are the counties of northeast Tennessee and southwest Virginia. And by the way, those ones in the lower left corner are simply counties for which there were no data reported. And you can see that 93% of our counties fall in the bottom half. 2/3 fall in the bottom quarter, and in fact 25%, a quarter of our counties fall in the bottom 10% nationally. So certainly if you're looking for one of the reasons why health is worse in central Appalachia, certainly smoking is one of those factors. What about the second one on the list, obesity? If you look at the distribution of obesity, our region compared to the country, there's northeast Tennessee, there's southwest Virginia, 95% of our counties fall in the bottom half, and over a third fall in the bottom quarter. And I could certainly go through the rest of this list, but you begin to get the idea. Now, a few years ago, if we had this meeting, this is where I would have stopped. I would have said, well, folks, the problem we have in Appalachia is that our health statistics are our health behaviors are so much worse than they are elsewhere. But we're increasingly coming to understand the importance of social circumstance, the so-called social determinants of health. We used to say that someone's health was driven largely by their genetics, what they inherited from their parents. Then we came to understand that their access to health care made a difference. Certainly their behaviors make a bigger difference yet, but really there are a variety of other factors that directly impact health. And as you look at this list, of course, they all make sense to you. I'm only going to talk about 2 of them, the first being income. Income matters to us in central Appalachia for 3 reasons. One, we know that income is related to health. If you look at the risk of dying before the age of 65 in America, you see a 3-fold difference between wealthy people and poor people. Poverty does matter to health. The second reason it matters to us in Appalachia, if you look at the distribution of children in poverty, again, 84% of our counties fall in the bottom half of Americans and 42% fall in the bottom quarter. The third reason that poverty matters to us in central Appalachia is that there are good data to suggest to document that the gap between rich and poor is getting wider in our country. This is income changes over 40 years. The left side shows the poorest fifth of Americans, the so-called lowest quintile. The bars on the right show the top quintile, and then there's 1971, 1981, 1991, 2001, and 2011. And what you can see is that the income average, this is constant dollars, the income average for the lowest quintile in 1971 was 10,300. By 2011, it had gone up all of 8.5%. During the same time frame, the income for the top fifth went up by 51%, so the ratio actually increased by 39%. In other words, the gap between rich and poor is getting wider. If you look not at the top quintile, the top 5%, the gap increased 67%, and the farther up you go, the more it shows the impact. Now, I'm not making this to make a political statement because I'm not a political person. I'm saying this because it matters. If you believe, as I do, that poverty is tied to poor health, you begin to realize that if we want to improve our health in Appalachia, we've got to see economic development and growth. The only other one of these I'm going to show you is education. And again, the same three reasons. It matters to us because, first of all, education is tied to health. If you look at life expectancy at age 25 by educational level, you see that for both men and women, there's somewhere between 5 and 7 years of difference life expectancy between someone who has a college degree and someone who's a high school dropout. The second reason education matters to us in Appalachia is because our level of achievement is not surprisingly below the national rate. And the third reason it matters to us in Appalachia is, once again, there are data to suggest that the gap between educated and less educated areas of the country is getting wider. This is a chart that shows the probability of a high school sophomore getting a college degree in 10 years. And what it shows you is that if your parents are professionals, you have a 73% chance of getting a college degree in 10 years if you're a high school sophomore. If your parents, on the other hand, are high school dropouts, that's only 5.9%. A 12-fold difference in the likelihood of getting a college degree in 10 years for a high school sophomore based on their parents' educational level. And what this means is that those parts of the country with less educational achievement will see widening gaps over time and not narrowing gaps unless we focus on getting more kids through the educational process. I could talk about this chart a great deal more, but I think it's pretty obvious that what we need to do to improve health in our region is what we need to do to improve health in the United States. We do have to make sure that folks have access to affordable health care, including preventive services. We also have to focus on behavior change, but we also have to focus on jobs and education. And we've got to recognize that these three things are inexorably interlinked. Every employer will tell you what they need is a healthy, educated, drug-free workforce. Every educator will tell you they need a robust tax base, economic development, and healthy kids and students, and so on. So those are the things we need to do. To put it into words, we need to work together to assure access to health care, especially preventive services. We need to work together to encourage healthier behaviors, and we need to work together to enhance economic opportunity and improve educational achievement. And what these all have in common, of course, is we need to work together. These are not problems for Washington, D.C., or Nashville, or Johnson City to solve on their own. They're not problems for doctors, or educators, or documentary filmmakers, or philanthropists to solve on their own. These are problems we have to solve together. Now, when I say this to audiences, people often have one of two reactions. They say, well, that's interesting, but it's not really my job. I'm a teacher. I run a small business. I'm an elected official. I make films. I'm a dean of public health. The truth is, we're all in this together. Virtually all of us can say with honesty that one of the reasons we do what we do is we want to give our children and our grandchildren a better life. So yes, it really is our job. And the second thing that people say is, well, it's important, I understand, but it really is too big a challenge to try to change the health of the people of our region or the people of the United States. But in thinking of this challenge, I want to go back to this picture and introduce you to the person in the upper right-hand side. He was a physician born about 12 counties up from here in the 1850s. He went out and joined the military as a physician during the Indian War, came back and became the public health officer for Charlottesville, Virginia. And I'm interested in him because at the time he was working, around 100 years ago, these were the leading causes of death in this part of the country. And you can look at this list and realize that in those days there were no antibiotics, there were no vaccines, there were no magic bullets. This guy and his colleagues could easily have thrown up their hands and said there's nothing we can do. But rather than that, they did something quite remarkable. They improved life expectancy in this country by 30 years. 3 decades. Most of those advances in the first half of the last century. Now, the reason I'm interested in this guy is not because he was famous, not because there are things named for him, but because he was my great-grandfather. And I often wonder, what would it be like to work at a time where the health challenges seemed too great? There's another picture in the Virginia Health Bulletin from 100 years ago that I think says more about what we have to do to improve health in Appalachia today than any textbook or any lecture that you could read or hear. And here's the picture. On one side of the wall are the leading infectious diseases, causes of death of those days: diphtheria, scarlet fever, measles. On the other side of the wall were the rather oddly dressed children of the day. They didn't throw their hands up 100 years ago and say there's nothing we can do. They knew they could build a wall. They called it popular education, careful physicians, and so on. And they said, how high is the wall in your town? Well, today the leading causes of death have changed, but there's still no magic bullets. But we can still be just as optimistic as we were 100 years ago that we can protect our children and give them a better life. Perhaps today we would call the wall providing prevention, changing behavior, providing access to health care, improving education and economic development. But we can be just as optimistic that if we build this wall together, we can give our children a better life. Building a wall will work anywhere in this country. Every part of the nation could benefit. Every state in the country will benefit, but probably nowhere more so than here in central Appalachia. You've met my great-grandfather in the upper right. That's my son Kevin in the upper left. That's my son Gregory driving the raft in the lower left corner with the rest of my family. And I close with this slide, as I always do, because I want to remind people that what I'm talking about has nothing to do with politics. It has nothing to do with statistics. It has to do with whether we, as leaders of this community, will make the kind of decisions that we need to make to give our children a region that is as healthy as it is beautiful. Again, I apologize for not being there with you. I'd be happy to answer any questions that you have or provide any additional information, and I very much hope to have the opportunity to see you all again in the near future. Thanks a lot for your time, and good luck with your efforts.